Assalamu alaikum and welcome to the radiology session for ICON 2022. Today we'll be having some diverse talks on artificial intelligence, vascular imaging, teleradiology, as well as whole body MRI and oncological patients. So as you can see, it's quite a knowledgeable session. We are honored to have some international and national speakers from renowned institutes. And so without further ado, let's start with our first talk by Dr. Ahtesham Junaid, who is a consultant radiologist in UK at Princess Wales Hospital, Britain. He is particularly involved in artificial intelligence radiology research, and he is also set up the AI lab at the National Imaging Academy of Wales. He is a peer reviewer on artificial intelligence for clinical radiology and British Journal of Radiology. Dr. Ahtesham will be giving a talk today on artificial intelligence in radiology, challenges and opportunities. So we'll be. So we are just about to pull up his talk. Dr. Ahtesham, this is his second talk for Indus Hospital. He came here personally last year, and now he'll be giving his recorded talk, inshallah, right now.
Talking about the opportunities and challenges in AI. And I'm sure you've heard lots and lots of things about AI in the last few years. It's pretty much the dominant topic in most radiology circles as well as conferences. The talk about radiology and AI and even sort of in health has had a lot of hype recently. Here's a Gartner's hype curve. And most of us can fairly confidently say that we're sort of in the trough of disillusionment, where there's a lot of investment. A lot of companies have invested billions over the last few years into this field. But the actual adoption within the medical sector hasn't been as what people had expected. The return of investment for the companies hasn't been there yet. And a lot of the companies which was initially set up have pretty much disappeared. So I think we're going to head to a more realistic approach to what AI can do. Initially, there was a lot more than people thought. And here's what sort of we see, a demo versus reality, where what you hear at conferences, you might hear at various presentations, but actually what reality is. And it's essentially what a lot of have experienced. So what are the opportunities available for us in AI? And I really, to be honest, this in itself is a very, very long topic. And I think I'm going to focus on a handful of things where I think realistically, where a lot of the departments for the radiology point of view can start looking into implementing very soon. One of the cool things about AI, a lot of people think AI is going to replace radiologists. It will suddenly make the radiologist or the image interpretation side of things redundant. Far from it. In fact, one of the key aspects of AI is actually before the patient is even imaged, particularly in improving image quality in CT and MRI. So, for example, in CT, in fact, it's already implemented by the major vendors, even within in my own department. So, for example, AI-driven CT reconstruction of imaging has been now around for a year or so. This allows for quicker reconstruction of imaging, a truer reconstruction of imaging. And for example, if you had all the time in the world and all the processing time in the world with the current CT scanners, you could reconstruct a really nice image, but that would take too long. So what they've done using AI is actually try to reconstruct high-level images, high-quality images from a normal quick scan. The other thing we can do with this is actually reduce artifacts, metal artifact reduction, motion reduction. In terms of MRI, also using there've been lots of papers about creating a 3 Tesla image out of a 1.5 Tesla image, sharpening, and one of the key things I see for AI in this sphere is many people have older generation MRI scanners, and using the AI to actually just clean up the images, to remove some of the speck, to remove some of the noise that you get from some of the older scanners. And those sort of products are actually coming into the market. So these sort of things will not replace anybody's job. They'll, in fact, if anything, save the department money, because rather than having to invest in a lot of new things, you can actually leverage AI to do that. We also can do is motion correction, especially with cardiac imaging, where motion is a big problem. And so not having to rely on such big detectors and such big CT scanners, which will capture in the whole motion in one beat, we're actually allowing for some of that motion to be corrected by more regular CTs. One of the really exciting things about AI in the MR field is actually speeding up the images. So in MR imaging, there's always a trade between speed and image quality. So if you want a really nice image, you can scan an MRI knee for 1 hour. Really, but that's not feasible. So if you can speed up that process, in fact, already people have got the MRI of the knee using AI in less than 5 minutes, really kind of improving image quality, i.e. taking slightly lower image quality and speeding up the process into a higher image quality using AI. This will allow departments to scan more people, and also, especially with children and patients who are in pain, they'll move around. So if you can scan the patient very quickly, it reduces motion artifact as well. So that's kind of a side benefit of speeding up MRI. In return for departments, so this will have a good return of investment, because you can scan, say, for example, in 1 hour, a normal MRI scanner, you might be able to do 3 patients. This might allow you to do 5 or 6 patients, so improving productivity for the same level of kit. So stuff like this, it's out there, and it's on the market. It's coming on the market. So these are real opportunities for departments to get involved in straight away. One of the things my own research is involved in is because I've been involved in setting up an AI lab in my own department and in the consortium we work in. So it's called the Imaging Academy of Wales. And one of the things that we're working on, as well as a lot of groups are working on, in fact, this is one of the key things which has been very popular, is prioritization using AI. So, for example, chest X-rays, for example, are the most common radiological study performed. Average hospital will produce something like 200 to 300, depending on the size of the hospital, per day. So if we can actually, and reporting that, many hospitals have big backlogs of reporting chest X-rays, and in some places, depending on the hospital, they're not even reported unless the report is asked for. Not in the UK, but I know it's outside the UK that's the case in some places. So using the AI algorithms, which are actually pretty available. In fact, we're implementing in our own department an algorithm which is commercially available, is just prioritizing what's normal and what's abnormal. So the normals will also be reported, but not necessarily at the same time. So typically, reporting happens. Reporting happens on a time basis. So this scan was done the oldest, so report this first. But actually, why should we report it like that? We should report the most abnormal first, because something that's abnormal needs action first. So that's an area of development. And the good thing about AI, it's much better at answering questions which are simple, rather than making it very difficult. What's the exact pathology? Is this pneumothorax? Is this pneumonia? Is this heart failure? Is it pleural effusion? Because then the accuracy starts going down. Where simply normal, abnormal, or very abnormal, or indeterminate. So those sort of things will help prioritize work. So you focus on, and that's where also help the workforce management within the department, where you only have set number of hours for your staff, for your radiologist and reporting colleagues. So at least if you've got a prioritization system, they can work on the abnormal bits. The normal stuff can come slowly. The same thing applies for urgent, non-urgent things. So, for example, CT head, CT brain, acute injury. Again, CT head is probably the most common CT we perform, and then that's probably the case in most departments as well. So, again, sifting through what's urgent, what's anything particularly of concern in any scan, that can be reported by the duty radiologist immediately. And so these sort of things already exist. A lot of them are coming on, are getting better every day. So something like this can be implemented much with ease. Opportunistic CT. Opportunistic CT. So, in fact, if you see some of the companies out there which have been doing really well, have been focusing on a handful of things. A CT produces a lot of data which we can help the patient for the future. They may come in for a thromboembolism or an acute abdomen or perforation, but there's other data on that scan which can help the patient in the long run. Sarcopenia, so that's associated with mortality. Coronary artery calcification, again associated with mortality. So these sort of things, and again, algorithms already exist to help us extract the extra data. Fatty liver, osteoporosis. These are all things which can be departments can develop this themselves, or this is something that can be also off the shelf available as well. So this sort of quantitative data can be then added to the report and added to the follow-up of things, and finding patients within the population which may benefit from treatment for something else that they also would require. The radiology report is also another key area of development. In fact, not only do we deal with images, our report is in a text format, and so the old reports and the new reports, a lot of algorithms now are working on using that data, to actually, if it's a new report, any words in the report which sound urgent, so that word will get detected by the algorithm, and it'll trigger a workflow as a result of that. It might be an alert. In the report, you might say something like, there is a pneumothorax, and immediately the word pneumothorax causes an alert to go to the emergency physician who's looking after the patient. As well as from a research point of view, if you want to harvest and really look through your old reports and find out what's what to help with the labeling, again, AI can help with that to really getting out old reports and matching them with images that you're looking for. So those are a few things I wanted to talk about. There's lots of things, but I think those things are within our grasp, and most departments can start implementing them very soon. Now, one of the challenges with any solution you'll heard of, there are lots of different, so very bitty, and very fragmented. So one company is offering a solution to look at chest, one company is offering a solution to look at brain bleeding, another solution. So there are lots of fragmented solutions, and I think what we're heading towards, hopefully, is a more integrated solution where it's a bit like for example, on your phone, you have lots of apps, but they all work together on the phone to deliver a service to you as the mobile phone user. So I think that's what a lot of companies are heading towards, where they have common ways or common platforms that they work on, which are easily can be deployed onto your servers. The key challenge, obviously, within development of AI is data, and especially data sharing and patient privacy, and that's becoming more of a talk, and it always has been. But thankfully, a lot of the challenges are being overcome by policies within the departments. But this area of study is getting more and more mature. People are developing policies and practices and guidelines, and the actual accountability aspect of things with this. So this is actually a big. A lot of departments get really frustrated about this, how they start. And the key thing to this is de-identification, DICOM de-identification. The free text of the report may have some data which may identify patients. A lot of times we have images which are part of the patient study which are not DICOM data. So those sort of things will also need to be de-identified. For example, an ultrasound image. Some scans will actually burn the patient data onto the image. So even if you remove the DICOM data, the image still has a patient's name. So those sort of things have to be worked on. Now, this is the key thing I really want to talk about, is data bias. The vast majority of algorithms out there are based on data from American, Western European patients. And that's really key, because that really determines how well your algorithm will perform. Essentially, AI is using data to train and then giving you an answer. So that the answer will depend on what data it's been trained on. There's already so much work out there proving that how algorithms are biased towards certain ethnicities and certain races, simply because that is the data that is being given to them. And unfortunately, this is a slide I took from, and you can see how the number of databases which are available nationally, from which is what is available for training. You can see US, China, UK, and Western Europe, and Australia, Japan, really providing there's no mention of Pakistan, and not even sort of some of the Asiatic countries in here, sort of the subcontinent. And this will really reflect on the accuracy of the algorithms. So my real take home message from this section is actually data sharing for the common good is actually should be encouraged. I've spoken to a lot of institutions in Pakistan, and there's a lot of reservation of sharing data. Now, big American universities are happy to share data. They have made available their anonymous. When we say sharing data, it goes without saying that everything is anonymous. So that's not even discussed about anonymity. That's something that's already given. But big institutions, American institutions, and UK British institutions have made their own data available for the learning, or for people to learn from that, for algorithms to get better. It's only in the interest of the population to share its own data. Um, I really would encourage that this will help us through this platform to actually get institutions thinking about actually let's make our data available, going through various channels, and those sort of discussions we can have. We really need Pakistani data sets. Pakistani patients are unique. The pathology we have is unique here, and so having that data available for the common good is really, really key. And it's not a unique ask. This is what a lot of Western countries are doing. A lot of big institutions are doing. What this does now, you can share data in two ways. You can have unlabeled data, so that an institution can say, we are making available 50,000 chest X-rays from our hospital or from our institution for people to learn. It's all anonymized, but there is no diagnosis associated with this. These are just 50,000 chest X-rays for anybody to learn from this. Or you can say, actually, we've sat down, and we're making available a data set of 50,000 chest X-rays with what we think is the predominant diagnosis. Take it or and so you will suddenly get companies as well as other institutions collaborating with you with your data set to develop algorithms which will help your population. And so that's really, really key, because a lot of things that are out there, in fact, very, very few, if none at all, have had any real Pakistani data set. One of the key ways of getting over some of these things is actually having knowledge and training in this. And nobody's expecting the medical community as a whole to become programmers, etc. But there are a lot of good programs, educational things out there. There's a really good one from Stanford on the fundamentals of machine learning and for healthcare. I'd recommend you have a look at that. Also, something very interesting. If you haven't done this, please do this yourself. Visit this website called lobe.ai, and this lets you, again, this is a initiative from Microsoft, and it's free, where you can actually learn a bit of AI without having any coding knowledge. All you would do, remember, you just upload data, label it, and you train the algorithm. So this is really, really interesting, and I don't want to spoil what the whole, but it's very, very, you can train, not just use it for radiology, use it for other things, but essentially it's an image-based algorithm which you can train. So the data stays with you. People have tried it with radiology. It has got some benefits, but again, they got even children using this, getting them used to how AI works, or the principles of AI, and you can actually use it for your own actual implementation of AI. For certain things, it's very good. So I hope you found this useful. My real take-home message is, again, I think some of the opportunities are out there which are very, very much within the grasp of the medical community right now. You can implement them, especially before the image is actually taken. You've seen that I didn't mention anything about reporting using AI. It's very much in and around when the image is taken and the action from when the patient has been imaged. And the real challenges is data. And I really would, request departments, whoever is listening, as well as if you really collaborate with sharing data for the better of the society, and it'll really help the Pakistani population and the subcontinent, because our patients are similar. Definitely, Pakistan is unique, and so I would really, really encourage the hospital, especially Indus, with a huge amount of data, coming up with a safe way of sharing and collaborating with other institutions. Thank you very much, and if you have any questions, please feel free to email me as well.
Thank you, Dr. Ahtesham. Thank you, Dr. Ahtesham, for a very enlightening talk. Our next speaker is Dr. Umar Tariq. He has graduated from King Edward Medical University in
Hello. Thank you very much for having
2009. He has done his radiology residency and IR fellowship at Giesinger Medical Center. He is currently working as a vice chairman in interventional radiology at the University of Pittsburgh Medical Center. He has received numerous research related awards as he has had multiple publications in peer reviewed journals, and he is also a peer review he has also done a peer review for renowned journals such as BMJ. He founded the Association of Pakistani Radiologists in North America. So, Dr. Umar, please continue with your talk of basics of vascular imaging, what radiologists need to know.
Hello. Thank you very much for having me as a speaker. My name is Umar Tariq, and I'll be talking about basics of vascular imaging. I'll be talking about various pathologies of aorta, pulmonary artery. We'll be talking about different types of vasculitides, mesenteric vessels, pelvic and extremity pathologies, and renal pathologies. So starting with aorta. So just quickly, we know about the normal branching anatomy, which is seen in 66% of population. We have a 3-vessel arch. The most common anomaly is the bovine aortic arch, when there's a common origin of brachiocephalic artery and left common carotid artery. It is seen in 13% of the patients, more commonly in Blacks. It's incorrectly referred as a bovine aortic arch because the true bovine aortic arch, which is seen in cattle, it just has a single great vessel arising from the aortic arch, and all the great vessels arise from that. 4-vessel arch is the next most common one. It is seen in 6% of the population. In this case, there's direct origin of the left vertebral artery from the aorta, and the left vertebral artery is the third aortic branch proximal to the left subclavian. Aberrant right subclavian artery, it is seen in 1% of the patients. This happens when right subclavian artery arises directly from the aortic arch, distal to the left subclavian, and loops behind the esophagus on its way to the right arm. So a related pathology to this is a dysphagia lusoria. This happens when there's esophageal compression resulting in dysphagia from the aberrant right subclavian artery. When you do a barium esophagogram, you can see a posterior indentation on the esophagus. It's very important to mention the presence of aberrant right subclavian artery. If a thyroid surgery is planned, then the recurrent laryngeal nerve might not be at its usual location. And also sometimes what you can see is a small bulge at the origin of aberrant right subclavian artery. It's known as Comerel's diverticulum. Talked about aortic anatomy, we will be talking about different aortic syndromes. So starting with penetrating atherosclerotic ulcer. Penetrating atherosclerotic ulcer happens when an atherosclerotic plaque penetrates the intima and it ulcerates into the media, but the adventitia layer is intact. So moving on to intramural hematoma. Intramural hematoma happens when there's rupture of vasa vasorum, which creates a crescent-shaped hemorrhage limited within the medial layer. It may be associated with an aneurysm. Now in the example, this is a non-contrast CT scan. You can see this hyperdense crescent here. And on the contrast-enhanced axial CT scan, you can see this relatively hypodense, non-enhancing component, which represents an intramural hematoma. Dissection is when intima is disrupted, typically by an ulcerative plaque. Could happen from trauma and aneurysm too. There is an intimomedial flap which is created, and the media is then dissected, and there's creation of a false lumen. Blood flows slower in the false lumen, and sometimes it can be thrombosed, but typically it enhances less as compared to the true lumen. Now, this is a perfect example of a aortic dissection. This is the intimomedial flap we were talking about. Now, moving on to the types of aortic dissection, typically we have Stanford A and Stanford B. Stanford A is when it arises from the ascending thoracic aorta. It can or cannot involve the descending thoracic aorta. Then we have the Stanford B aortic dissection, in which case it arises from the descending thoracic aorta. So the question is, why do we have a differentiation of type A versus type B? Type A is considered emergent because there is urgent surgical management that is needed. Because it arises in the ascending thoracic aorta, it can cause coronary artery occlusion. It can rupture into the pericardium, which can result in a tamponade. It can also cause dissection into the aortic valve, resulting in aortic insufficiency. The big question is, what do we call an aortic dissection that arises in the arch of aorta. So this was a very good paper that talks about any dissection that arises in the aortic arch is not a type A, it is type B, because we typically don't have to worry about the complications that are typically associated with type A. So comparing the intramural hematoma with the aortic dissection, the intramural hematoma would have a fixed crescent-shaped. It would be hypodense and enhanced on CT angio. There will not be any intimal flap, whereas in aortic dissection, there will be a false lumen, which will be partly enhancing, unless it's thrombosed, and there will be an intimal flap. Again, this is a very good example of an intramural hematoma. As you can see, it's crescent-shaped. On non-contrast images, it's hyperdense, whereas in contrast-enhanced images, it doesn't enhance that much. Moving on to pulmonary artery pathologies, starting with pulmonary hypertension, you will see an increase in diameter of main pulmonary artery equal or greater than 2.9 centimeter. Also, the main pulmonary artery diameter will be greater than the aortic root diameter. Pulmonary artery calcifications are also known for chronic pulmonary artery hypertension. In addition, you can also see mosaic attenuation. You can also see ground glass centrilobular nodules and ecchyses. Moving on to pulmonary AVM, when there is an abnormal connection between pulmonary artery and pulmonary vein, we call it a pulmonary AVM. It causes a right to left shunt. When there are multiple pulmonary AVMs, we call them as hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rendu syndrome. It can typically present with brain abscess, stroke, or recurrent epistaxis. For treatment of pulmonary AVM, place coils to embolize them. Particles are typically contraindicated as there is a right to left shunt, which would cause brain emboli and infarction. Indication for treatment, if it's an asymptomatic lesion, you need the feeding artery to be greater than 3 millimeter in size. And for any symptomatic lesion, if the patient has a prior infarct or a brain abscess. Moving on to vasculitis. So vasculitis, all of them, they pretty much have a lot of overlapping findings. The most important thing is age and regional distribution. These are all the different vasculitides that we will be talking about, starting with large vessel vasculitides. So aortitis in an acute phase, it will show circumferential mural thickening and enhancement. There may be associated aneurysm or dissection. Typically, aortic wall thickness will be greater than 2 millimeter, and there will be enhancement of the aortic wall. Takayasu's, also known as pulseless disease, it typically involves the aorta, coronary arteries, subclavian arteries, carotid arteries, pulmonary arteries, and large mesenteric arteries. It's typically seen in women aged less than 50. In this case, you will see a long, smooth stenosis, which is classic. Imaging-wise, it's indistinguishable from giant cell arteritis. So this is a perfect example of Takayasu arteritis. Here you see long, smooth stenosis of the great vessels. Here you see long, smooth stenosis of the aorta. So moving on to giant cell arteritis, also known as temporal arteritis. In this case, the patient's age will be greater than 50. There's typically involvement of extracranial head and neck arteries. Upper extremities are commonly affected, especially subclavian, axillary, and brachial arteries. Aorta is rarely involved. Aorta is typically involved in Takayasu's arteritis. And again, you will see long segment stenosis and occlusions. It can typically present with headaches, polymyalgia, visual changes. Definitive diagnosis is with temporal artery biopsy, and treatment is steroids. Moving on to Behçet's. Behçet's will typically present with multiple pulmonary artery aneurysms, typically seen in young male. Moving on to small and medium vessels, we divide these into two groups, ANCA positive and ANCA negative. ANCA positive will include polyarteritis nodosa, Wegener graminosis, Church-Strauss syndrome, Kawasaki disease. So polyarteritis nodosa, as we know, T-ANCA will be elevated. We will see multiple visceral aneurysms. Moving on to Wegener's. Wegener's, you can see cavitary lesions in the lungs. You will see septal perforation. There will be tracheal stenosis. Church-Strauss syndrome, you will typically see this in the lungs. There will be multifocal consolidation, ground glass opacities, multiple nodules. The last one of these is Kawasaki disease, in which case you will see multiple coronary artery aneurysms. Moving on to Berger's disease. Berger's disease will affect lower extremities. It's typically seen, as we know, in adult male smokers. The primary treatment is smoking cessation. You will see segmental stenosis of the medium and small arteries in the leg. It's typically described as corkscrew collaterals will be seen in the vasovasorum. Moving on to mesenteric vessels, starting with splenic artery aneurysm. The indication for treatment of a splenic artery aneurysm is when there is aneurysm size of greater than 2.5 centimeter or prior to expected pregnancy. These are known to rupture during pregnancy. or if the patient is symptomatic with the left upper quadrant pain, the treatment of choice is endovascular coil embolization. It's the most common visceral aneurysm. It's typically seen in multiparous females and patients with portal hypertension. They're at increased risk. There is increased risk of rupture during pregnancy. Moving on to median arcuate ligament syndrome, or also known as Dunbar syndrome. This happens when there is a celiac artery compression by median arcuate ligament, which typically worsens with expiration. It's typically asymptomatic, present with crampy abdominal pain. The treatment is surgical release of the median arcuate ligament. Again, this is a very good example showing median arcuate ligament syndrome. These are the sagittal images in deep inspiration, and these are sagittal images in deep expiration, showing worsening of the compression of the celiac artery origin. Multiple additional examples showing compression of the celiac artery origin. Moving on to SMA syndrome, also known as Wilkie syndrome. This happens when there is significant compression of the duodenum between aorta and the sphygmomesenteric artery. It's typically seen in thin children, bun victims, or patients who have lost a lot of weight recently. This is just a cartoon depicting the same phenomena. On an upper GI, you will see significant compression of the duodenum. Multiple additional images showing the same phenomena on a CAT scan. For diagnosis, they typically suggest looking at aortomesenteric angle. You measure this angle, and if there is a significant reduction of the angle and there is decrease in aortic mesenteric distance, that represents the pathology. Moving on to Nutcracker syndrome. Nutcracker syndrome happens when there's compression of the left renal vein between aorta and sphygmomesenteric artery. You will see pain, hematuria, orthostatic proteinuria, pelvic congestion, and varicoceles. Majority of the cases of hematuria resolve within 2 years of observation. If treatment is desired, the typical treatment is angioplasty and stenting of the renal vein. So basically, going back to the previous cartoon, in the SMA syndrome, the duodenum is compressed. In Nutcracker syndrome, it's the left renal vein which is being compressed between the sphygmomesenteric artery and the aorta. So this is another example in which we see multiple enlarged gonadal veins and large periuterine vessels. You see this large gonadal vein, multiple periuterine venous plexus. This is all collateral circulation because of significant compression of the left renal vein between the sphygmomesenteric artery and the aorta. So the treatment is typically angioplasty and stent placement. Moving on to pelvic and extremity vessels, starting with Lariche syndrome. It's a chronic occlusive atherosclerotic disease of the distal abdominal aorta. It typically presents with impotence, claudication, absent femoral pulses, and cold lower extremities. As you can see, there will be complete occlusion of the distal abdominal aorta. There is no contrast going into that region. Moving on to May-Turner syndrome. May-Turner syndrome is typically when there is venous thrombosis of the left common iliac vein caused by compression by the crossing right common iliac artery. Treatment is typically thrombolysis followed by stenting. This is a perfect example. As you can see on the axial contrast enhanced image, there is thrombosis of the left common iliac vein because of compression by the crossing right common iliac artery. Treatment, like I said, is thrombolysis followed by stent placement. Moving on to pelvic congestion syndrome. It's a non-cyclical chronic pelvic pain caused by dilatation of the uterus and ovarian plexus. It's accompanied by dilated, tortuous, and congested veins caused by retrograde flow through the incompetent ovarian vein valves. So what you will typically see is there will be significant dilatation of the ovarian veins secondary to valve failure and obstruction. There will be significant varicosities in the periuterine region. So typically you treat it with coil embolization of both gonadal veins. So this is an example showing coil embolization of a gonadal vein. You started with the left side and then you coil embolized the other side. Moving on to popliteal entrapment syndrome. Popliteal entrapment syndrome is when there is completion of the popliteal artery by a calf muscle or fibrous band, and the treatment is surgical release. As shown in this image, you will see it worsening in active plantar flexion, and it will be better with passive dorsiflexion. Moving on to cystic adventitial disease. It's a rare cause of distal claudication when one or more mucoid cysts are present in the adventitia surrounding the popliteal artery, resulting in significant luminal compression, and treatment is surgical resection. Thoracic outlet syndrome is typically accompanied by compression of brachial plexus, subclavian artery, or subclavian vein. When the vein is thrombosed, it's called Paget-Trotter syndrome. It will be typically accompanied with upper extremity paresthesia, pain, numbness, and coolness. So the important thing about thoracic outlet syndrome is that there is this interscalene triangles, brachial plexus and subclavian artery pass through the interscalene triangle, whereas subclavian vein does not pass through the interscalene triangle, but it runs anterior to the anterior scalene muscle and posterior to the subclavius muscle. Treatment is thrombolysis. If it doesn't improve with thrombolysis, then a surgery might be needed. Moving on to Hypothenar-Hammer syndrome. In this case, injury to ulnar artery happens when it crosses the hamate bone from chronic repetitive trauma. Perfect scenario is a jackhammer operator with ischemia of fourth and fifth digits. On angio, you will see occlusion of the ulnar artery with distal embolic occlusion. Multiple additional examples showing ulnar artery occlusion in the case of hypothenar hammer syndrome. This green circle shows how it should look, whereas all these red circles show pathology of the ulnar artery, either there is significant stenosis or occlusion. Moving on to renal vessels, we will be talking about fibromuscular dysplasia. It's an idiopathic vascular disease affecting primarily renal and carotid arteries. It affects middle or distal third of the renal arteries. This is an example. As you can see, the perfect beaded appearance of the fibromuscular dysplasia. The treatment is simply angioplasty without stenting. And that concludes the session. Thank you.
Thank you, Dr. Umar, for a very, very concise talk on a very vast subject. I think you compiled it very well. Our next talk is by Dr. Nadeem Akram Bhatt, who has graduated from King Edward Medical College, did his MRCS and clinical training from Edinburgh, and then continued on with his radiology training in Glasgow. He is a MSK radiologist at HealthPoint UAE. And he also is in liaison with with FRCR, conducting courses, and he is involved in PACS-based online fellowships in UAE and Saudi Arabia in Radicon. He will be giving us a talk on present and future of teleradiology. Please, Dr. Nadeem.
Radicon Institute, Abu Dhabi. I know you are expecting Dr. Nadeem for this talk, but he had to travel suddenly, and I am honored to do this talk. Welcome to ICON 2022, Teleradiology, Present and Future. So this talk is meant to answer a few of the most common questions about teleradiology. So what does teleradiology mean? How it differs from conventional radiology? Who is teleradiologist? And what do I need to make my teleradiology setup as a radiologist or as a hospital? What are the fuss with this jargon like DICOM, PACS, RIS, EMR, HRS, EHR, VNA, HL7, and why should I do it? What are the benefits? What's the catch and how to do the risk assessment? What are the do's and don'ts and how it will it be augmented in future and may take an entirely different shape? So what is teleradiology? By definition, it is a practice of a radiologist interpreting medical images while not physically present in the location where the images are generated. So, a radiologist can report these images from literally anywhere. So, he or she has the access to the images or radiology information system. Now, here's the question. When do you think it started? When was the first time that teleradiology was achieved and how? So we all know that radiology started in life in 1895 when Röntgen discovered X-ray. But how about teleradiology? Well, the first breakthrough came in 1947 when a radiologist named J. Cohen and an inventor Austin Coley joined hands and tried using fax technology to transfer images. They worked on it for 3 years and published a paper in JAMA, which is the Journal of American Medical Association, and called it Telegnosis. So the next major achievement came in 1957 when Albert Jutras in Montreal successfully transmitted images through a coaxial cable. So teleradiology was officially born, and now radiology images could be sent to other locations. It could be to another hospital, a teleradiology hub, a special image post processing lab, or a conference, OT or clinical pathological meetings, or multidisciplinary team meetings. And finally, the favorite of all rods, they could do home reporting. So lastly, teleradiology has lost its name as teleradiology, and as it is considered official and mainstream radiology practice where up to 40% of American imaging were using teleradiology for one thing or another. This is how an old X-ray reporting room looked like. So there are shelves and aisles with x-ray packs everywhere. So it was cumbersome with x-ray packs being ripped, multiple studies being mixed. Additionally, it was particularly difficult as images could be present at only one place at a time. So you could send this to radiologists or clinics or theater or a meeting. But now everything has changed. Now, this is the phase of radiology images. So, images can be simultaneously loaded anywhere on a workstation or ward computer, in a clinic screen, or even on iPad. So, there are certain vendors who are providing images on mobile screens. Let's have a look at this. So, this is one of the most common memes in recent pandemic, where radiologists claim to be doing social distancing for so long. Teleradiology just made it worse, and some authors are even considering concept of teleradiologists as a group of chicken or hen locked in a cage and bound to do one single task, produce a product at a faster rate. So be it an egg or a radiology report. Radiology or teleradiology these days is full of jargons. You are familiar with most of them, but here I want to touch upon this briefly. First, we have is the DICOM, or the Digital Imaging and Communication in Medicine. And then we have the PACS, or Picture Archiving and Communication Systems. We have the RIS, or the Radiology Information System, and then EHR, or electronic health record. So it is also known as electronic medical record, or EMR, or hospital information system, or HIS. So we also have the storage, which can be a hardware or a cloud. So it can be in a form of a remote workspace using a thin client server. So further images can be stored in two types of storages. One is immediately accessible, known as nearline, and the other holding images from more distant past, known as the farline. DICOM stands for Digital Imaging and Communication in Medicine. It was developed by a joint effort of American College of Radiology and National Electrical Manufacturing Association in 1993 as a tool for standardizing medical images, especially focusing on the file format and the transmission protocol. So each image or DICOM object had certain embedded parameters or tags, such as the ID, date, modalities, center, grayscale. So its position in the stack of images and even name of the operator or referring clinicians. So it could even carry the format report without the transmission protocol. So there are two main parts of DICOM standards. So the first one is the Grayscale Presentation State, or GSPS, which had image display information. The second one is the Grayscale Standard Display Function, or otherwise known as GSTF, which was responsible for the calibrations. So it needs to be added that DICOM images needs a DICOM viewer for display images. So a standard DICOM viewer can be found on official websites. However, there are numerous vendors use this open source software while made their own DICOM viewers as a plugin to the back system. So DICOM format lacks storage and access as it needs packs for that. So PACS provide storage and convenient access to medical images such as ultrasound, MRIs, CTs, and X-rays. So PACS use digital imaging and communications in medicine or your DICOM to store and transmit images. So store medical images, almost always DICOM, while DICOM can be accessed without PACS. So we have five key functionalities as shown below, and it connects the RIS, EHR, speech recognition system, primary diagnostic reading stations, enterprise display workstation, and radiation dose engines. So here you can see the digital radiology department in its workflow. So the image suite or workstation is at the center and exchanging information from numerous other places simultaneously. So from 11 o'clock, it gets the RIS information from the reception or booking office or other appointment section or financial centers or your HIS. So from right top of the screen, you can see it receives images from scanning rooms, remote stations like OT, and send images to various outputs like storage or data burning in right lower corner. So this information is then available for physicians and patient care areas as shown in the left lower hand side of the slide. It results in a fairly smooth and quick digital workflow where a patient is scanned, then images are sent to PACS, then a radiologist is informed who reads the images, then are results are transcribed and report is available instantly. Teleradiology has tremendous impact on how radiology departments are working around the globe. It can be used to get a second opinion from tertiary care center or subspecialty report from expert within the network or outside the network. Although computer-aided diagnosis or detection has no direct dependence on teleradiology, but their symbiotic relationship is creating one of the most powerful impacts in the history of radiology. As CAD or CADX can be expensive tools and not many centers can afford all of these. However, teleradiology achieves centralization or decentralization, making it a huge volume of images, which allows use of specific tools at a given center. So, in easier language, hospital does not have to buy all the softwares like CT colon package, cardiac CT package, liver transplant volume imaging, and Alzheimer's follow-up brain volume. So these specialized studies can be done locally and then processed at an independent lab, which could be provide this service in a pay-as-you-go basis without a long-term billing. So teleradiology has a profound impact also in terms of the turnaround time, which means the time gap between images acquisition to report availability. So now reports can be created from a remote location on an available radiologist, even if a no radiologist is available on site. And then teleradiology has impact on cost reduction as well as it drives down expense on various fronts as well, and we will discuss it in detail later on. Then teleradiology also allows double reading or the double signatory for each report, which can be used in many ways, ranging from training to quality assurance, clinical governance, auditing, such as a peer review service. And the most favorite aspect of teleradiology among radiologists is the quality of life. So, where evening and night images can be reported by someone else in a day zone. So, now let's look at these factors in a bit more detail. Now, let's review a case scenario. So, a certain patient had trauma CT far away from a major city. Now, an actual CT slices with 12 or 16 or even 20, 24 images on an X ray film is unlikely to give full information, especially when a local rad is not available. So, let's export that image to Lahore or Karachi Indus unit where MPR can result in sagittal images and show multiple compression fracture of vertebral bodies. Teleradiology has the capability of providing far better patient care in the right setting. So even in existing manpower and resources, so it helps creating an environment where most tailored and best possible report can be generated, which is fact most valuable to the patient. So frankly, just like us, even patients want access to the best possible medical or radiology opinion on their respective diseases. The Radiology Information System or RIS component of modern radiology departments allows a good analysis of total studies done, studies reported, and can monitor level of backlogs. So it can also break down based on modality, body part, or specialty and helps considerable in workforce planning. So, for example, if a large number of liver MRIs are pending to be reported, hinting at the need for body radiologists, then this fact can be fed into the HR planning. So, in the meantime, teleradiology can help with centralization or remote access where those liver MRIs can be reported by someone who has special interest of training in this. So this is one way how teleradiology contributes to faster turnaround time and more timely patient care. Now let us discuss about cost. Cost seems to be the most hype and promising features in corporate health sector where large business enterprises intend to cut down on operational costs of the radiology department and save as much as possible. So let's look at that. Operational costs, also known as operations expenses or shortcut is OPEX, mainly represent two things. First one is your technical fee or the image acquisition or the technological salaries. Second is the professional fee or also known as the radiologist fee. So teleradiology basically does not address the technical fee and focuses only on the professional fee. So financial factors which affect the reduction of OPEX are faster patient care and timely decision, resulting in reduced hospital stays, resulting on indirect cost saving. Timely reporting of scan, reduce reduction in complaints and fines by insurance companies or regulatory bodies or legal settlement, which is another cost saving. So it's reduce insurance fines, reduce professional fee. This is a critical point as a private companies or hospital try to use teleradiology as a mean to reach out to wider range of radiologists and sometimes even non-rads to find a report on pay-as-you-go basis or pay less for some study by the same or less qualified rads. So this has affected the radiologist's income in a significant way and formal accounts of enterprises shows that non-rads like cardiologists or gynae bill more than radiologists in imaging. So it can be explained on a variety of reasons, but nonetheless, it has affected the radiologist's income. So reduced overall radiology costs have also resulted from some wider factors in the Western world where other factors have come into play, such as cuts to imaging reimbursement by national healthcare legislation. So reduction in unnecessary imaging, reduction or reduce duplication due to the digital images availability, and worldwide health spending deficit reduction. We already touched upon these points, but let me recap that one. Teleradiology allows double reading or double signatories for each report, which can be used in many ways, ranging from training to quality assurance, clinical governance, auditing reports such as peer review service. Teleradiology as Nighthawk service has been a significant development. So at a global scale, certain time zones in USA and Pakistan are 12 hours apart, which means that a teleradiology contract between respective institutions can result in a midnight American scan to be reported at lunchtime. On a lighter note, as when Pakistan rupee value rises against dollar, the reverse will also be possible. So by the way, this comment was added by Dr. Nadeem himself, so please don't blame me for this. As a matter of fact, UK scans are being reported in Australia using the same time gap principle. So it has a certain benefit in workforce as local radiologists can have good night's sleep without having to wake up multiple times in night, already sandwiched between two busy working days. So same principle can use within a country or an organization with mutual agreement between different hospital on a network. So now let's have the risk assessment. Well, all of the facts so far sounds pretty convincing in favor of teleradiology, but there are certain factors which must be looked at. Things are not simple as one may think. When we break down the costs and try to reduce the operational expenses, we need to consider one more expense, which is called the capital expense. Capital expense or capex represent initial or baseline investment. So capex is almost always high for digital radiology and teleradiology. So one has to spend more on latest hardware which has DICOM capability or high resolution display monitor which are always being replaced by better ones. Likewise, initial software cost is also higher where PAC system, RIS system, teleradiology setup, its licenses, storage or cloud space, and secure VPN and IP address linkage will result in substantial cost. then the operational expenses need to be considered at the planning level. So there are various pay models available where providers agree on a pay per scan, which is billed at the end of a certain period of time. Slightly business centers tend to get a better rate as block volumes, for example, guaranteed 10,000 reports a year. So while calculating these payment models, there are variables like modality. So as you can imagine, CT and MRI reports have higher billables than plain film. Similarly, time available for providing reports also influences the payment model where emergency scans are billed at a higher rate. The teleradiology provides also face a cost of image transfer fee. So if they don't have an enterprise setup with own storage, cloud, firewall, VPN, and connectivity, then using a third party can result in unit image transfer fee, which can be as high as approximately $4 per X-ray and even higher for CT and MRI. So there are of course other consumables and variables such as staff salaries in teleradiology setup, such as your IT, your transcriptionist, and or the VR license. So despite all these advances in radiology department, it has been observed that imaging represents the slowest growing category in the fee for service Medicare program. Another important factor around detailed radiology is patient confidentiality and legal compliance. A lot of countries do not allow overseas export of the healthcare data with patient identifiers. So, for example, for sometimes scans from England could not be legally reported anywhere in the world except Australia and South Africa. Even in those countries, these scans can only be read by radiologists which are licensed to practice in UK, despite the fact that at the time of reporting, they are physically present in Australia. National laws, geographical restriction, and need for professional or individual licensing provides a good discipline in a potentially uncontrolled teleradiology growth where radiology departments would soon become online market of services with no quality control. Having said that, enterprise solution in various softwares allows anonymization as an additional layer before images are sent into another country. So these anonymized images are reported and then sent back to the original country, then they anonymize and link again to original ID. So likewise, professional licensing requires most often applies to final report only and not preliminary reports, which results in a large number of draft preliminary reports which are then reviewed in original source of images and then released that has potential of not only professional misconduct but also radiologist identity theft. So another debate is about teleradiology access into local system, which can be PACS or RIS or HIS. It is most often provided as an online access using VPN tunnels and reporting RAD or external provided can see all possible information about any patient in a local environment. An alternative is exporting the DICOM images into external software, which has considerable clinical disadvantages to reporting RAD as previous medical history or relevant recent imaging will not be available. Let's have a look at this image. Imagine this image was exported into your local PACS from another healthcare facilities. A junior resident is about to issue the report of multiple fracture dislocation in gross skeletal dysplasia, and luckily, a senior radiologist comes in and identifies that this is an x ray of a chicken from a vet center and can save a lot of embarrassment. In a less dramatic situation, look at these x ray images. It shows a straightforward spinal fixation between third and fourth lumbar vertebrae with a disc cage. That report is factually correct. However, if you have previous image available, then you could see that the patient has previous L4, L5 fixation, where L5 screws were removed and then the new L3 screws were inserted, leaving track marks in L5. Comparison results is far more comprehensive and relevant report. In context of developing countries, there are certain other factors such as affording hardware and software costs and need for complex radiology post-processing budget where endemic infective diseases like cholera, malaria, and dengue claim more life than disease requiring complex organ volume computation labs. Likewise, X-ray film printing or carriage is far less dependent on electricity, online servers, and cloud issues. So such ground factors certainly have choking effect on wide use of teleradiology. Teleradiology also has several issues affecting quality of healthcare. For example, teleradiologist is far less available to clinical team than a local radiologist. In absence of on-site radiologists, scan planning and protocoling is almost always adversely affected. Another important point is timely communication of emergency or critical findings for referring clinicians. A radiologist sitting in Australia trying to convey critical finding to a nursing colleague in Glasgow Hospital is expected to be more challenging than just connecting to local teams via hospital operator. Finally, certain modalities hard to be standardized are challenging to be reported by teleradiology. These are five key areas where teleradiology is going to shape the future of radiology on its own or in collaboration with another parallel healthcare aspects. It will affect the training and development, especially radiologist training in remote areas with lesser training facilities. You may be aware that one of the largest teaching hospitals in Lahore did not have an MRI on site till start of 2018, which left all residents in the training program at a disadvantage to learn the MRI at full capability. In such scenario, online cross-sectional or radiology fellowships can help obtain necessary experience and exposure. Some of you may be aware that Royal College of Radiologists in UK has been doing FRCR exams online remotely. So second, teleradiology features and apps will allow patients to carry their scans in their mobile phones. Thirdly, centralization will affect the workflow. And fourth, AI will be easier to integrate with centralization purely on financial justification, if nothing less. Finally, national health spine or health information exchanges where some or all of the hospital in the country or a geographical area can be connected on each other. A road traffic accident in remote areas can be immediately seen in one of the most advanced centers of the country. Now, let's combine all of the above to a potential case study. Let's assume that Dr. Kashif's Sashli and Indus hospitals do a large investment in teleradiology hardware and software to connect all Indus hospital and some other service providers too. A centralized hub is now created, which will have much high workflow and higher imaging revenue from internal as well as external referrals. Higher income can provide further investment in better and faster software as well as more post processing imaging modules. Let's add AI at this centralized hub. AI will be able to direct scans to radiologists based on their availability from sign in status, their experience, and subspecialized interests. Now, faster and streamlined workflow at Central Hub will result in more work in the center, leaving skeletal staff in satellite center to provide ultrasound cover. Now, more imaging can be done by fewer people using AI in workflow and CAD like bone age, pulmonary nodules, TB, pneumothorax, and fractures. They will be able to do a lot more work than previously conceivable. It will result in job losses for many as few people will take over as they are equipped with cutting edge teleradiology.
um, teleradiology. Now I would like to call Dr. Kashif Siddique. He is a consultant radiologist at Shaukat Khanum Medical Center who did his FRCR and FCPS in 2012 and 2013, respectively. He has done his fellowship in MSK Radiology from Royal Liverpool University Hospital in 2017. His area of interest includes oncological imaging, particularly bone and soft tissue sarcoma imaging. And today he will give us a talk on current application of whole body MRI in oncological imaging. Dr. Kashif, please. Dr. Kashif, you can unmute your microphone. And please share your screen. Also, I would just like to tell everyone, sorry, that please fill out this feedback forms in order to get the CME certificate. That's very important. That you must fill out the feedback form in order to get your CME certificate. Kashav, you will have to unmute your mic, please. Your microphone is muted. Dr. Kashif, can you hear us? Your microphone is muted. Yes, thank you.
Yeah. Can you please hear me, Dr. Shire? Assalamu alaikum.
Yes, we can hear you. We can hear you. Please
Okay,
proceed.
thank you.
And we can
Thank
also
you.
see your screen.
Yeah, thank you. Thank you very much. So just sorry for this little bit technical
Mhm.
error. Uh, I think I'm audible to all and my screen is visible to all. Is it? Assalamu alaikum. Thank you very much for my introduction and thanks a lot for inviting me for this talk. Today, I'm going to talk about the whole body MR regarding its technical aspects and clinical applications.
जी डॉक्टर काशिफ आप स्लाइड शो पे करके
Yeah,
अपनी स्क्रीन शेयर
yeah.
कर लें.
So it's not allowing me to move to the next slide.
अच्छा आप अपने कंप्यूटर पे?
Yeah.
ओके
So let me try again.
ओके जी
Do you have any technical support available? You can see my screen, but it's not allowing me to move forward to the next screen with using my own keyboard.
डॉक्टर काशिफ
जी
जी आपके पास आप अपनी वो स्क्रीन ऑन कर दें, लाइक प्रेजेंटेशन ऑन कर दें.
जी मैं इसको कर रहा हूँ, 1 मिनट जी.
इंटायर स्क्रीन शेयर
जी
करके देन आप अपने प्रेजेंटेशन पे चले जाएगा.
जी अब आपको नजर आ रही जी स्क्रीन?
अभी तक तो नहीं नजर आ रही. ओके, आई थिंक इट्स कमिंग. यस,
Yeah,
यू कैन
thank you
सी
very
इट नाउ.
much. So now it's scrolling down.
ओके, ग्रेट.
Okay,
आप
thank you
अगर
very much.
स्लाइड शो पे कर दें तो वो अच्छा, चलो
जी
रहने दें, इसी
uh,
पे कर लें. वी कैन सी इट
yeah, yeah,
एंड वी
thank you
कैन
very
हियर
much.
यू वेल टू.
Thank you very much.
ओके.
Really sorry for this technical glitch.
नो
We
नो,
will
इट्स ओके.
continue from here.
नहीं,
So
थैंक यू.
thank you very much for inviting me for this talk. So today I'm going to talk about the whole body MRI, its technical aspects and clinical applications. So in next 20-25 minutes, we'll try to understand the basic techniques involved in whole body MR, including commonly used pulse sequences. We'll try to discuss the emerging role of MR, whole body MR in the form of oncological cases and clinical applications. I will try to describe the role of whole body MR in various treating, diagnostic, and follow-up clinical algorithms. So, as we all know that CT and PET-CT are well-established imaging modalities for the oncological imaging. But as we all know that patients have to undergo lots of scans during their treatment course, and this has prompted interest for generating a modality which is causing less radiation to the patients. So in the form of whole body MR, there is the promising results coming up in the form of better local imaging of the tumor as well as imaging of the distant metastasis and the same imaging session. So the recent advancements in the hardware associated with the whole body MR as well as development of other sequences like whole body DWI sequences have broadened the range of diagnostic information which can be obtained in a single imaging session. So in its pure sense, the term whole body MR means the imaging of whole body from head to vertex in a single examinations. However, the specific pulse sequences, the imaging protocols, imaging planes for this scan would vary depending upon the institutional practices, hardware available in that institute, resource availability, the time you have to image the whole body, how the patient tolerate the scan, and the type of study you are doing it. The combination of moving tabletop and a modular array of dedicated multi-channel, multi-echo coils covering the entire body has become the preferred hardware configuration for whole body MR. The most common pulse sequence that is used in the whole body MR and the more common commonest plane which is used for the whole body MR is the coronal acquisition, and particularly the coronal stir sequence is widely considered the cornerstone for the most of the whole body MR imaging protocols because of its robust fat suppression and excellent pathological lesion conspicuity, particularly for the marrow lesions. So this table tells us the different sequences and the planes used by different people for the utilization of whole body MR, particularly for the pediatric population. And you can well see that most of these protocols do include coronal stir as the basic cornerstone sequence as well as plane. On top of it, you can add the axial sequences depending upon the clinical question which you're going to ask. You can add sagittal stir sequences if your interest is look for the spine. But the take home message is that the coronal T1 and coronal stir sequences are the basic main cornerstone for the whole body MR combined with DWI imaging which are obtained in the coronal sequence. So let's talk about few of the pathologies which we can have a better understanding with the whole body MR, starting from the lymphoma. FDG, PET, and PET-CT remains the standard of care for staging and treatment of lymphomas. For staging, for response evaluation, particularly in the pediatric population. However, as we earlier said, the large cumulative radiation dose which a child is going to have throughout the period of his treatment has prompted the interest of use of whole body MR for these patients. Whole body MR has also been studied for extranodal staging of lymphoma, for visceral infiltration of the disease, for the spleen. The use of positive criteria are the splenic size and the presence of focal lesions can be used involvement of the spleen in lymphoma patients. For bone marrow involvement, MR has good agreement with PET-CT findings, although the the gold standard still remains the bone marrow biopsy. So whole body MR can be used for evaluating treatment response in lymphoma, particularly in patients who have undergone multiple therapies of chemotherapy. With multiple studies have suggested that the rapid increase in ADC values that far outpace the morphological change in the tumor size, and this is analogous to the early decrease in the metabolism seen at the FDG PET. So decrease in FDG PET is equivalent to the increase in the ADC values that we see in whole body MR. In addition, in one of the studies, they demonstrated that DW has high sensitivity for detection of residual disease after completion of the lymphoma therapy, and that a specific threshold value of ADC can be used as a distinguishing point in deciding whether the residual soft tissue, which is left over, is actually a fibrotic tissue or is there any viable tumor left in it. Now let's talk about few examples. So you can see that at the top two images, we can see axial T2 image, we can see bilateral supraclavicle lymph nodes, and the upper top right corner, we can see the DWI sequence where it's an inverted gray DWI sequence where you can see the high signal intensity within these nodes, assessing the disease involvement. And the same patient, bottom, the middle two images demonstrate the CT and PET-CT component of the same patient corresponding to the areas of lymph node involvement with evidence of dissection in these nodes. If you go a bit down in the thorax, we can see large mediastinal lymph nodes. On the lower bottom left corner is the T2 image of the whole body axial sequence. On the right lower corner is a CT sequence, CT image. So the first image describes the presence of abnormal signal intensity within the right cervical recesses in the form. So this is the, as I earlier talked, this is the star sequence that is obtained for the whole body MR. We can see presence of enlarged right supraclavicular, right lower cervical lymph nodes, and the center image is the DWI coronal image demonstrating the high signal intensity in these lymph nodes. And the last image demonstrates the image from a PET-CT. So these are those patients which had PET-CT as well as DWI sequences. So you can well appreciate the presence of metabolically active lymph nodes in the last image corresponds to diffuse-restricting lymph nodes in the central image. For the Langerhans cell histiocytosis, the interest involves the interrogation of multiple anatomical sites which are susceptible to involvement by LCH. So this has a far higher sensitivity for skeletal disease than the plain radiography and skeletal scintigraphy. So seen in isolation, several of these features which are seen in LCH on the whole body MR have overlapping features with other malignant diseases. So biopsying these lesions is important. In addition, whole body MR allows evaluation of treatment response as well in the form of decrease in T2 stir sequence as well as presence of less diffuse restriction. Whole body MR is superior to FDG PET for detection of spine lesions, which can be facilitated by addition of sagittal star sequence. So these are images from whole body MR patient with LCH. We can see involvement of the left acromion by the expansile abnormal signal intensity lesion. There's another lesion within the right ischial tuberosity, and we can see the presence of splenic size. So multiple site involvements can be triggered, can be picked up with the whole body MR sequences. So other malignancies in pediatric population which can be imaged with the whole body MR with good results are a group of disease that we call as small round blue cell tumors that includes the neuroblastomas, Ewing sarcoma, and rhabdomyosarcoma. So for these diseases, the main appeal for whole body MR is the imaging of the primary tumor site as well as the imaging of the distant metastases. So MR generally excels in local evaluation and staging as compared to other modalities. As compared to CT and PET, MR has quite better, is superior to other modalities for local staging. For neuroblastoma, MR is also superior to CT for evaluation of the intraspinal extension. That has a limitation and that has some image-derived risk factor that can have surgical planning for this patient. So intraspinal extension is best detected with the MR as compared to CT and PET CT, and this is going to affect the surgical planning of these patients. Other differential possibilities which you consider when we talk about the neuroblastoma, like ganglion neuroblastoma and ganglioneuroma, can be easily differentiated in the with the help of DWI sequencing, because these lesions, ganglion neuroblastomas and ganglioneuromas, don't show diffuse resection, but the presence of diffuse resection would favor presence of neuroblastoma rather than these entities. In one of these studies, the whole body MR had a higher sensitivity for skeletal lesions in neuroblastoma than patients which had MIBG scan. Regarding distant staging, whole body MR is superior to skeletal scintigraphy and potentially equivalent to FDG PET for skeletal metastases. And this is the primary concern in many of the small round blue cell tumors to look for the distant metastases. Whole body MRI has also been studied for evaluating treatment response in solid tumors, and this treatment response can be judged by the decrease in size, by decreased stir sequence, as well as presence of less diffuse resection. So this is a images from the whole body MR for one of the patient with Ewing sarcoma of the right iliac blade, and we can see some abnormal intramedullary signal within the left proximal femoral diaphysis. The same patient had a PET CT and there was no metabolic activity, and on the CT component we can only see there's subtle loss of the intramedullary trabecular pattern, but this is showing very high signal on the stir, suggesting presence of a contralateral metastatic deposit in the proximal femur. The same patient had another lesion in the distal femoral metaphysis with high signal on stir and low signal on T1 weighted sequences, suggesting the presence of the distant metastasis in this patient with Ewing sarcoma. So as we talked earlier, MR in the form of whole body MR can detect the local tumor in the form of its staging as well as distant metastasis in the same imaging session. If you talk about the hereditary retinoblastomas, most of are caused by the sporadic and less commonly by the inherited germline mutation of RB gene. Whole body MR can serve as effective radiation-free modality for evaluating distant metastasis in these patients. With the advancement in therapies and multimodality treatment available, the children with hereditary retinoblastomas can now have a good survival outcome. But with this survival, there is a chance of developing second malignancies beginning in the late childhood. Some of them are related to therapy like osteosarcoma, other soft tissue sarcomas, melanomas, and cancers of the brain, orbits, and nasal cavity. So we need to image these patients with hereditary retinoblastomas in throughout their childhood. In a series of 25 patients with hereditary retinoblastoma, the researcher was able to track two osteosarcomas in this patient in that patient group with a sensitivity of 66.7%. So currently there is a debate whether to image these patients with whole body MR or not, but there has been promising results. And American Association for Cancer Research has suggested the use of whole body MR starting at the age of 8. So they decided the age of 8 because on the basis of the temporal pattern of second malignancies and reduced sedation needs beyond this age group. So another thing in which the whole body MR is performing far better than other modalities is the presence or detection of the systemic malignant bone disease. As we all know that bony metastases is the most common site for metastases in malignancies, and whole body MR can detect these metastases far earlier and far better than other modalities. Conventional imaging like CT and bone scintigraphy are widely used in detection of malignant bone disease, but these modalities lack sensitivity. Furthermore, the assessment of treatment response for the bony metastases is unreliable for these modalities. But the MRI, as compared to PET CT, can detect the treatment response for these patients, particularly with the help of DWI sequences. A prospective study comprising whole body MR and FDG PET in 98 patients found that the sensitivity of whole body MRI is far greater than FDG PET for the detection of osseous and hepatic metastases, whereas whole body MR had lower sensitivity than FDG PET for detection of pulmonary metastases because of the presence of smaller sized nodules. So that's one of the limitation of whole body MR to detect the pulmonary metastases as compared to PET CT. Whole body MRI has been reported to have similar or better diagnostic accuracy than PET CT for metastatic disease and myeloma. This holds particularly true for lesions that are PET negative. Not all bony metastases are PET avid, particularly in cases of lobular carcinoma and renal cell carcinoma. So as we know that these are the PET negative metastases. So in these particular entities, the whole body MR performs way better than the PET CT to look for bony metastases. And we all know that the PSMA negative bony metastases are less detectable on the PET CT, and in those patients, whole body MR also performs better. So MRI has also accurate for assessing skeleton complications with associated bony metastases such as spinal cord compression, impending cord compression, and vertebral fractures. In prostate cancer, whole body MR is useful for assessing the response for metastatic bone disease and is recommended in the latest American Society for Clinical Oncology ASCO guidelines for advanced prostate cancer for the detection and response assessment for advanced case prostate cancers. Let's talk about the multiple myeloma. So whole body MR is now recommended for all patients with suspected of having asymptomatic myeloma or a solitary plasmacytoma for the detection of disease-defining lesions. So conventional MR, as we all know, has a superior sensitivity than compared to PET CT for the detection of small focal marrow lesions. The same principle is used for the whole body MR to look for small marrow infiltrating lesions throughout the body. So the speed, the quantitative capabilities, and superior sensitivity of the whole body MR compared with conventional sequences have led to its adoption at several leading myeloma imaging centers as a first-line imaging modality. So additional benefits include the assessment of skeletal complications and no use of intravenous contrast. So a study at Royal Marsden, they took 20 pair of scans, and those patients had whole body MR as well as PET CT. These patients were diagnosed to have myeloma. So there was a positive correlation between the whole body MR and PET CT for the detection of bony lesions. However, the mean whole body score for whole body MR was significantly higher than those for PET CT. Another thing which is picked up better and clearer is the diffuse disease where you don't have focal lesions but there's diffuse marrow infiltration. So PET CT performs way better than the PET CT in myeloma with diffuse disease. So In one of the study, they demonstrated the whole body MR is highly sensitive quantitative imaging technique for detecting diffuse and multifocal marrow infiltration in patients with multiple myeloma, and can be used for assessment of the response therapy as well. This supports current international myeloma working group guidance that MR should be used for imaging investigation of choice for detection of myeloma marrow infiltration, given its higher sensitivity than PET-CT. So, how is the patient experience while having a whole body MR? We know it's a time-consuming study. The average time that a whole body MR took would be around 45 to 60 minutes. So, in one of the study which took around average time of 49 minutes, 86% of patients found the overall experience not at all too unpleasant as compared to other imaging modalities. And 93% patients said that they would be happy to have this examination again, suggesting this imaging technique is acceptable to the patients. So whole body MR detects a statistically higher burden of myeloma disease than PET-CT scan. Whole body MR also outperforms PET-CT in assessment of disease infiltration of the iliac bones, essential for good clinical correlation for tree-fine results. So the International Myeloma Working Group now recognize the presence of more than one focal bone marrow lesion. So that's defined a lesion more than 5 millimeter in size on MR as an indication for starting systemic therapy for patients with suspected myeloma. So from 2016, the National Institute for Clinical Excellence has given guidelines that position the whole body MR as an imaging technique of choice for all patients with suspected diagnosis of multiple myeloma in the UK, with increasing evidence and adoption for monitoring, response assessment, and restaging. So this is one of the practical examination. The first image is the whole body MR, in which we can see there is diffuse infiltration of the marrow with some focal lesions within the ribs on this DWI inverted grayscale image. And the central one is the image from the PET-CT, where you don't see any focal increased metabolic activity, and the last image where you can see the focal lesions. So in multiple myeloma, the whole body MR can detect diffuse marrow infiltration as well as the presence of the focal lesions. So if you have focal lesions, you are going to target those focal lesions for sampling through the percutaneous biopsy. So in pediatric population, particularly with AML and ALL, who are going to have high dose steroid therapy during the course of treatment, they are prone to develop multiple complications. And one of the most common complications associated with the steroid therapy is the osteonecrosis. So owing to the poor correlation between the lesion size and symptoms, many of these patients do present late when they have larger defects in their articular surfaces. The potential morbidity which is associated with the involvement of the osteonecrosis can be picked up earlier by use of whole body MR as a screening tool, given in higher sensitivity as compared to bone scans as well as X-rays. So as a basic whole body MR protocol for osteonecrosis includes the STIR and T1 weighted coronal sequences to assess the multiplicity, distribution, and extent of the articular surface involvement. Because the involvement of the articular surface has some clinical implication for the involvement of the joint cavity. Whole body MR is advocated for any patient experiencing musculoskeletal symptoms during or after the high dose steroid therapy for a hematological malignancy, particularly for ALL and AML. So this is one of the example in which the child presented with no specific limb pain and joint pain. The axes were normal, but if you look at the STAR sequence, you can see a classical bilateral intramedullary abnormal signal with peripheral high signal and central low. And on the T1, corresponding area has a peripheral rim of low signal intensity. Typical in the appropriate clinical context, the imaging features are specific for osteonecrosis in these patients. Once detected, the steroid therapy has to be stopped immediately so as to stop the progression of this osteonecrosis. So in our center, we are doing whole body MR for pediatric population in a small subset of patients, particularly with Ewing sarcoma. Because for the Ewing sarcoma, for the pediatric age group, most of the time we have to give sedation, and to avoid sedation for another bone scan, we are using the stitched imaging, in which we are using multiple coils to image whole body, and all the then imaging planes are stitched together like we do the whole spine sagittal stitching digitally. The whole sequence like station 1 to 5 can be stitched together, and the central one is a beautiful cornel star image detected for picked up for the whole body MR in the form of this image. And on the last you can see the T1 cornel image, which is also stitched by acquiring different stations together. So this is called digital stitching when you compile the imaging together. And you can see abnormal marrow signal within the articular surfaces of both knee joints, in keeping with osteonecrosis. So strengths of whole body MR includes its multiparametric capabilities, the higher conspicuity for the marrow lesions, higher conspicuity to pick up brain, liver, and musculoskeletal abnormalities as compared to other imaging modalities. So owing to its versatility, whole body MR is highly adaptable to the patients and indications. Wide field of view acquisition is optimized for efficient whole body screening, such as probing for distal metastasis in patient with the cancer of unknown primary. So targeted regional examination with smaller field of view smaller field of view and high resolution techniques can then be used to either interrogate findings detected with the screening sequence or provide high sensitivity for at-risk organs. There are some limitations associated with whole body MR as well. So for my experience, the most important is the time constraints, because average time would be 50 minutes for the whole body MR. It's not considered accurate to track the lung nodules, particularly nodules less than 8 millimeter. We still have to use CT to screen for the pulmonary metastases. As with all whole body imaging techniques, detection of false positive findings, non-specific or incidental findings, which we are going to pick up on the whole body MR, can also prompt further diagnostic evaluation with ionizing radiation or invasive sampling. To conclude, whole body MR is a versatile tool for a radiation-free imaging that can continue to rapidly evolve. Effective implementation and image interpretation rely on the understanding of both its strengths and weaknesses along with limitations. The high soft tissue contrast resolution, good improving spatial resolution, wide anatomical coverage, and non-invasive nature of whole body MR can potentially lead to change in existing clinical pathways for managing various cancers, particularly in the pediatric population. Thank you very much for this talk, and this is my references, and I would like to take any questions if asked. Thank you very much.
आपके एक्सपीरियंस में शौकत खानम में हाउ मच आप लोग कितने एमआर करते हैं होल बॉडी?
So we are doing around 10 to 15 in a year. It's not commonly used. It's particularly used for, as I said, for Ewing sarcoma in pediatric population. We do around 15 in a year.
Okay, so आप कह रहे थे कि for multiple myeloma, it's also it's one of the main. It's more superior than PET CT for detecting myeloma lesions. तो आप specific cancers में करते हैं?
Yes, it's not used for all. In our setup, we are only using for the pediatric population because we don't have multiple coils. For the smaller babies, it's easier for us to digitally stitch those sequences, as I showed you in one of the images. To cover an adult, we need to have multiple coils, so that makes it difficult to stitching these patients.
Right. ठीक है. और आप लोग शौकत खानम में कब से कर रहे हैं?
So we have been using it for last 4 to 5 years.
Okay. Thank you very much. It was a very good talk.
Thank you very much. My pleasure.
Dr. Umar, I would like to ask you a question that आपने इतनी extensive talk, इतने कम time में, I don't know how you compiled all of it together. You went through multiple pathologies and you gave us a good overview with images. तो आपके experience में in which vascular type do you come across most?
You know, honestly, I think it's aortitis. Giant cell arteritis is the other one, and Takaya. So it's a combination. You know, it's not easy for me to say that. Most of the times, you know, these go undiagnosed it's very tough for us to zero upon this is this type of vasculitis, because the treatment is steroids, right? So unless you do a biopsy, just a giant cell arteritis, you will do a biopsy and come across one pathology. Other than that, it's just typically, you give steroids irrespective of whatever the pathology is.
Right. We do encounter, it's not so frequent, but we do come across some arthritis, and diagnosis karne mein, there's, you really have to put the clinical with it, because it's not always a very clear-cut picture. एक और आपने
Absolutely.
pelvic जी
जी.
Sorry,
Yeah, that's
आप
what
कह
I'm
रहे
saying
थे?
कि जो जितने भी vasculitis है ना, इन सब में imaging findings will not help you. It's the distribution, age, and the clinical presentation that will help you more. हाँ, थोड़ा सा you can say कि अच्छा, if you're seeing pseudoaneurysms, then it's more likely to be PN as compared to if you're seeing long smooth stenosis, then it's probably Takayasu, giant cell arteritis, something like that.
Right.
So you were going to ask
also you were
another
talking
question?
about pelvic congestion syndrome. So we actually, when often in reporting, we do come across like a congested vessels in the pelvis, and we label it as pelvic congestion syndrome. तो आप क्या, I mean, I don't, यहाँ पे इतनी embolization होती नहीं है, maybe because they don't get the workup done just for pelvic congestion syndrome, but over there in the US, आप लोग क्या on a regular basis करते हैं treatment for pelvic congestion syndrome?
Yes, we do. और उसमें ये है कि typical आपको clinical picture पता होनी चाहिए, और clinical picture ये होती है कि patients who stay up, who are a lot on their feet, nurses हैं, जिसका PAs हैं, तो ऐसे लोग जो कि अपने पैरों पर होते हैं, पूरा दिन काम करते हैं, and then they complain of pelvic pain, which gets worse at the end of the day.
Right.
So that's a perfect picture. Uske baad, you do imaging findings and you want to rule out other pathologies. By other pathologies, I want to say that you want to rule out May-Turner syndrome. You want to rule out Nutcracker syndrome. So you want to make sure the patient does not have prominent pelvic varicosities because of other pathologies like May-Turner or Nutcracker. And if none of these are present, and you see a prominent gonadal vein with prominent pelvic varices, then in that case, yes, absolutely, we will do, gonadal vein embolization.
Okay. Thank you very much, Dr. Umar. Your talk was, like I said, it was a very extensive topic that you took on, and you presented it very well in a very short amount of time. So that was really good.
Yeah, it was a little tough to compile it in 15 minutes. Last time I gave this talk, हम लोगों ने पूरा घंटा लगाया था, but I tried to summarize it. Lekin hopefully we can do it in more.
It seemed like something which could have taken an hour. So I'm very impressed कि आपने इतना उसको compact करके present किया था. I don't know if Dr. Ahtesham is with us. Is he there? He's not there? Okay. Chale, that's fine. We can just ask him his question later. I want to thank you very, very much for joining us for the session. Dr. Umar, thank you. आप बीच रात में उठ के आपने attend किया है according to your US time. Dr. Kashif, thank you very much. You came live. Also, lots of thanks to Dr. Nadeem, who had to have his session recorded on his behalf. And of course, Dr. Ahtesham for giving us a very good talk on artificial intelligence. And thank you for making our session a success. And inshallah, we hope that you give us this opportunity of giving us talks in the future as well. So thank you very much.
Thank you very much.
We'll just end our session here now. Thank you.